Good morning, everyone. Welcome to Providence Medford Grand Rounds for June. Uh, Today, we're happy to have Dr. Rachel Sanborn from the Providence Cancer Institute speaking on immunotherapy advances in lung cancer. Dr. Sanborn is a full member of the Earl A. Childs Research Institute at the Providence Cancer Institute in Portland, where she serves as medical director of clinical research as well as medical director of the thoracic oncology program and medical director of the Phase 1 clinical trials program. She serves the additional role as medical director of the Franz Hematology Oncology Clinic and leads a robust portfolio of clinical trials that include cutting-edge research in targeted therapies, novel treatment approaches, and early-stage and combination immunotherapeutics for lung cancer, other thoracic malignancies, and other cancers. She's a member of the Providence Institutional Review Board, the American Lung Association Medical Advisory Work Group, as well as the Southwest Oncology Group Lung Cancer Working Group, serving as co-chair of the Metastatic Lung Cancer Subcommittee. She's a member of the Lung Cancer Research Grant Scientific Review Committee for the American Association for Cancer Research, the Scientific Program Committee for Developmental Therapeutics, Immunotherapy for the American Society of Clinical Oncology, and a member of a Global Task Force for Women in Thoracic Oncology for the International Association for the Study of Lung Cancer. And we're happy to have her join us today. Good morning, Dr. Sanborn.
Hi, good morning. Thank you so much for the invitation to join, and thanks to everybody who's joining online on an early Thursday morning to talk about lung cancer. It's not usually the thing that gets people up and out of bed, but I appreciate you joining and the invitation to speak. So I was asked to give a presentation and an update today on immunotherapy advances in lung cancer, and I titled this Leaps and Limits. To talk about both where immunotherapy has advanced and the areas in which immunotherapy does not have a role as we think about an overview for lung cancer. So first of all, these are my disclosures, and these will be available as well with the slide deck and the presentation. To set the field as we think about lung cancer and put this in perspective, these are the most recent publications of lung cancer statistics in which lung cancer is still the second most commonly diagnosed cancer in the United States for both men and women. And we see that along the top here. Unfortunately, lung cancer still remains the #1 cancer killer, however, of both men and women in the United States. And this is also the case globally. More people die from cancer worldwide from lung cancer worldwide than any other cancer. This is still globally the most common cancer killer. When we move this into thinking about things more regionally, and let's think about it by our state here, then in 2026, there's still almost 3,000 cases of lung cancer estimated to be diagnosed in Oregon in 2026. Now, the mortality thankfully is dropping, and we will talk about why. However, over 1,600 people in our own state are estimated to die of lung cancer this year. The lifetime probability of developing lung cancer for men and women for the first time is now equalized, with having a slight decrease in the incidence of lung cancer in men. If we look at the statistics over time here, the red lines show the declining incidence of lung cancer in men over the decades. We have now, after a crest, hopefully are starting to see a decline in the incidence of lung cancer in women. But still the lifetime probability of lung cancer in men and women in in Oregon is 1 in 19 for each. So if we think about the number of attendees here, or if you go to clinic or you go to your next work event and you look around that room and you start to do the math, you realize how many of those people may develop lung cancer. Not all lung cancers are related to tobacco exposure. If a person has lungs, they can develop lung cancer. One of the major impacts in reducing lung cancer mortality is lung cancer screening. And lung cancer screening with a low dose annual screening CT has been proven to reduce the risk of death from lung cancer by 20%. That's a really powerful number. With the current USPSTF, US Preventive Services Task Force guidelines, eligibility right now for lung cancer screening includes patients or people between the ages of 50 and 80 who have at least a 20-pack year smoking history and who have quit within the last 15 years or who are continuing to smoke. And the recommendation for this group of people is for annual low-dose screening CT. Unfortunately, what we know in the United States is that the minority of people who fit these eligibility criteria actually get screened. And in addition to that, what we know are that there are many people who have a risk for lung cancer with lesser tobacco exposure, with other types of high-risk chemical exposure, who aren't within these guidelines. And many people who are diagnosed with lung cancer are left out of this screening eligibility. So these are sources of active discussion and ongoing research. When we talk about lung cancer, people tend to think of it as one type of disease. But the important thing to keep in mind with this is that lung cancer are actually hundreds of different kinds of cancers that occur within the lungs. We start by grouping things into some broad subtypes first, with this looking at how we categorize the spectrum of disease. So the most common subtype of lung cancers fall into what we call non-small cell lung cancers. And among that are the subgroups of adenocarcinoma, squamous cell carcinoma, and then we get into the more poorly differentiated non-small cell, not otherwise specified group. From there, if we think about things in a spectrum, there are those non-small cell lung cancers that express neuroendocrine markers, and we think about large cell neuroendocrine carcinomas there. Moving from there into what we think of our carcinoid tumors, grouped into typical or atypical carcinoid. And from there, we get into the more poorly differentiated neuroendocrine tumors that fit in the bucket of small cell lung cancer. Small cell lung cancer occur in fewer patients overall, estimated approximately 13% of lung cancers in the United States are small cell lung cancers. We do see plenty of these in Oregon. From there, though, that description doesn't end the diagnosis of lung cancer. And it's really essential, particularly for non-small cell lung cancers, to complete the rest of the diagnosis, which includes analysis of tissue, blood analysis for liquid biopsy, or both in many or most settings. And so when we're looking at these subtypes, then there is an entire array of other markers that we're looking at that have a significant impact on the diagnosis, response to treatment, prognosis overall, which can include targetable alterations as we currently think about them with PD-L1 expression, also HER2 and MET by IHC. There are a myriad of different types of mutations identified by next generation sequencing that when we talk about, say, an EGFR mutation, for example, there are multiple different subtypes of those mutations that have a significant impact in the types of treatment and the types of response that are available for those patients. The same occurs for KRAS mutations, RET rearrangements, and others. There are also other important findings that are identified by NGS sequencing that aren't currently targetable the way that we think about them, however, have a significant impact again in tumor behavior. So these pie charts are a brief overview of the mutation landscape for non-small cell lung cancer, where the pie chart on the left is an array of mutations that were identified for patients with early stage resectable non-small cell lung cancers to show the relative incidence of these mutations, with KRAS mutations being the most common. And then from there, we see EGFR, BRAF, and then many other mutations in the array. In the metastatic setting, which is the pie chart on the right, we see a similar array, although slightly different incidence for patients with metastatic disease. Now, these are snapshots only of some of the actionable targets as we think about them, but then there is an overlay as well that we see here about how other types of mutations that are identified on next generation sequencing have a significant impact in terms of how tumors behave and respond. And so, for example, if we look at patients with EGFR mutations, when there is a co-mutation of TP53 and RB1, for example, we know those patients have a very high risk of converting to small cell lung cancer, very short duration of disease control with just a targeted therapy toward EGFR. And we need to know the rest of the mutation status in order to be able to complete that patient's diagnosis and make decisions about their treatment. These overlaying mutations have a significant impact in tumor behavior in terms of propensity to metastasize, relative resistance or sensitivity to immune therapies, and interplays in the tumor microenvironment. So, grouping this into thinking about tumor by stage and cancer by stage, let's start by talking about resectable non-small cell lung cancer. And in the current era, one of the important things to think about is that for patients who have resectable non-small cell lung cancer, we have really moved into an era of looking at neoadjuvant treatment with chemotherapy and immune therapy for the appropriate patients before going straight to surgery. And at this point, only the earliest stage lung cancers, the smallest tumors, go straight to surgery. This is because there have been multiple randomized phase 3 trials in the perioperative setting where we see above the line here. These were studies. This was a study looking at neoadjuvant, either chemotherapy with immune therapy or combination immune therapy prior to surgery. Everything below the line were studies that looked at chemotherapy with different immune therapy partners, going to surgery, and then completing adjuvant immune therapy after the surgery. All of these studies showed a benefit in event-free survival with neoadjuvant or perioperative treatment, as opposed to straight to surgery and then adjuvant therapy. And multiple of these studies have now shown a benefit as well in overall survival. The other studies still have overall survival data pending because they are not quite mature, but this has changed globally our standard of care. And these are some of the examples of why. So the Checkmate 816 study was a randomized trial of neoadjuvant chemoimmunotherapy prior to surgery. And here, for patients, what we'll look at here is for patients with the earlier stage disease, stage 1B through 2, there was a significant benefit with the addition of nivolumab as a checkpoint inhibitor versus chemotherapy alone. And so here we see 5-year survival at 65%. Importantly, with this as well, for patients with larger and more advanced disease, stage 3 disease, who have a much poorer prognosis, interestingly, 5-year survival was also 65% with chemoimmunotherapy. So here we're starting to level the playing field for those patients who previously and historically before this era had very poor survivals. This is an exploratory analysis of the same study. You don't have to look at too many of the details here, but what we are looking at is that we see on the left on this survival curve an analysis for those patients who could obtain pathologic complete response with a treatment before surgery when patients went to surgery and nothing was left, no residual viable cancer. Those patients achieving path CR by whichever means, chemotherapy or chemoimmunotherapy, had a much better outcome than those patients who still had persistent disease at the time of surgery. Likewise as well, patients who cleared circulating tumor DNA in the blood by whichever means did better than those who did not. The key with this is more achieved either one with the perioperative and neoadjuvant immune therapy added. This was a different trial that was looking at a similar approach with neoadjuvant and adjuvant immune therapy, showing as well here that if one could achieve both clearance of ctDNA and have a pathologic complete response, those patients did the best compared with those who could not clear ctDNA or did not have a pathologic complete response. That was true for both patients receiving immune therapy or those who received chemotherapy alone. When we look then at starting to look at some of those patients historically who had some of the poorest outcomes, patients who had KRAS mutations, those who had a KEAP1 or STK11 overlay as well, we saw that there was a benefit for those patients with the addition of immune therapy compared with those who did not receive immune therapy. So let's put this into perspective. Starting with what we know about these cancers, then, we know that immune therapy improves outcome versus chemotherapy alone for patients with resectable non-small cell lung cancer, and that pathologic complete response and ctDNA clearance predict for better outcomes. But what we don't know at this point still is neoadjuvant chemotherapy enough? Can we add treatment just before surgery, surgery alone, and then no treatment afterward? Or is perioperative immune therapy, treatment before and after, better? We also don't know how many cycles of treatment people actually need in order to call it good. And we don't know whether we can make formal decisions about do we give further treatment or not based on pathologic response. We also see that there's still a drop-off in those curves, and there are still patients who have disease recurrence. So another question is, will other novel agents with combinations of immune therapy or the newer bispecific antibodies such as ivonescimab or others improve the efficacy and make this better? Because we still have room where we need to improve those curves. Now, enter here the exceptions. Those patients who do not receive a benefit for whom it is important to identify before they get any treatment. We'll start with what are called classical EGFR mutations. So this was a landmark trial, the ADORA study, that looked at patients with resectable EGFR mutated lung cancers with the classical mutations, what we call, those are EGFR exon 19 deletions and L858R mutations. And for this study, patients who had completely resected disease who received standard of care adjuvant chemotherapy were then randomized to either 3 years of osimertinib as a targeted therapy versus placebo. Now, this was at a time when patients had completed all of their standard of care treatment, in which watch and wait is the next step. So placebo is ethical because this is the next step, was fingers crossed and observation. What this study showed is that across each stage of disease, stage 1, stage 2, or stage 3, there was a benefit in overall survival adding the targeted therapy after the completion of standard of care adjuvant chemotherapy. Next, we're looking at moving osimertinib into the neoadjuvant setting. The NEO-ADORA trial was a randomized study for patients then with resectable non-small cell lung cancer, again with the same EGFR mutations. Now, these were patients with slightly larger tumors, who had the same mutations, slightly higher risk disease. And patients then received either chemotherapy alone, osimertinib alone, or chemo and OC as the combination before surgery. And so for this population, what received were there were fewer patients who had progression in the osimertinib arms. And over half the people who started with osimertinib in either arm were able to clear mediastinal lymph node involvement and have downstaging. Now, only about 20% of patients were able to achieve that with just chemotherapy alone. Now, the majority of people went on to receive adjuvant osimertinib as well in any of the arms. So that part was even, and that was the standard based on that previous study. What we see here on the right is that the major pathologic response rate was significantly improved, getting the targeted therapy compared with just chemotherapy alone, where only 2% of people had a major pathologic response. We're not even talking pathologic complete response, but just major response with chemotherapy alone. However, it's only still about 25% of patients using either targeted therapy or a TKI with chemo in this setting. Still, much improvement is needed here. Again, analyzing this by major pathologic response. Across these top lines is a merge of those patients who were able to achieve major pathologic response by any means here, any of the arms, did better and had improved event-free survival compared with, as we see below, in any of the arms, those who did not achieve major pathologic response. So again, this is a really important endpoint for us to try to achieve. So putting this into perspective for this population, what we know, and what we know as a baseline, which I didn't put all of this in here, but we'll touch on a little bit later, is that immunotherapy before osimertinib increases toxicity. We also know that neoadjuvant osimertinib improves major pathologic response. What we don't know, though, is does neoadjuvant osimertinib improve overall survival over time? Is osimertinib alone enough based on this, or do we need to have the chemo as well? And does the neoadjuvant osimertinib improve cure? Another exception. For patients who have ALK rearrangements, these patients also do not achieve a benefit from immune therapies with checkpoint inhibitors as we know them currently. So this was a randomized phase 3 trial that was a similar population of patients with resectable non-small cell lung cancer. For this study, patients had undergone surgery and then were randomized to either alectinib as a targeted therapy versus previous standard of care of platinum-based chemotherapy. So just TKI versus chemotherapy. And what was seen in this study was a significant benefit with adjuvant alectinib across the top lines compared with chemotherapy for disease-free survival. And this was across, first of all, those highest risk patients, stage 2 through 3 in the top line, followed by the entirety of the population that we see in the bottom here. Patients also had better control of disease in the brain with fewer events of recurrence in the CNS, which is an extremely important endpoint for patients with these rearrangements who have very high risk of recurrence in the brain. This is not the case, however, for just any targeted therapy in this setting. And this is a randomized trial of an older tyrosine kinase inhibitor, crizotinib, which was one of the original that we used for ALK inhibition. And this adjuvant study did not show any benefit with the older TKI in the same population. So we need the better, newer generation targeted therapies in order to improve outcomes. And in this study, then, patients were only able to tolerate treatment for about a year, and a significant portion of patients discontinued because of toxicity. So the less toxic, more effective, newer treatments are important. So this has prompted ongoing then investigation in the neoadjuvant setting with this targeted therapy. So looking at alectinib, this is just a snapshot of things to come, where this is a small trial, still a small number of patients who were given neoadjuvant targeted therapy before surgery. And these bars are showing that the patients who had either significant disease response, here we see between a 90 and 100% disease response, or pathologic complete response. Looking at these populations, this was very powerful treatment before surgery. And in addition, then about a third of patients had nodal downstaging, 40% or so had radiographic downstaging. More to come in this setting, but this is a picture of things to come. Now let's move into something that was very recently presented with another exception with RET fusions. And this data was just presented at the American Society of Clinical Oncology meeting a couple of weeks ago. This was a randomized trial for patients with RET rearrangements, similar population, those with resectable RET rearranged lung cancers. This was presented at the plenary session at ASCO. For patients who had resectable disease or patients who had early stage disease that could be treated with radiation as well, curative intent treatment, who had completed adjuvant chemotherapy at the time that watch and wait was appropriate, randomized to the targeted therapy selpercatinib compared with placebo, fingers crossed, alone. And in this study, there was a significant benefit, as we see on the top line, for event-free survival. This was by investigator assessment, starting first with the highest risk population, those with stage 2 or 3A disease, compared with the watch and wait approach, with a hazard ratio of 0.172. In the field of lung cancer, a hazard ratio that low is extraordinarily uncommon and was extremely exciting to see. Now, when they then moved to the next statistical endpoint, which was incorporating the entirety of the disease stages, including stage 1B, that same event-free survival was still persistent with a very similar hazard ratio. And both of these were confirmed by blind independent central review. So the presentation of this study a few weeks ago changed the standard of care globally overnight. Now, we are still waiting for FDA approval to catch up for availability of this, but across the globe now, this is considered the standard of care approach for patients in this population. Now, let's move on to those patients who do not have resectable disease. So unresectable, stage 3, non-small cell lung cancer. The Pacific trial demonstrated that after curative intent chemoradiation, then the addition of consolidation immune therapy significantly improved overall survival. And here we see a significant improvement with almost 43% of patients still alive at 5 years with the addition of consolidation immune therapy compared with the prior standard of care, which was watchful waiting and observation. We also see a significant difference in progression-free survival as well. Those patients still alive who do not have cancer progressing or cancer recurring. So this has been our standard of care for patients without actionable targets. However, what we know in those populations, again, is that if a person has a classical EGFR mutation, the addition of that consolidation immune therapy does not provide a benefit. And so looking at other ways to help people in that setting, this was a randomized trial for those patients who had classical EGFR mutations, getting curative intent chemoradiation, and then randomized to receive osimertinib as a targeted therapy, in this study given indefinitely, versus placebo. Again, the standard of care here is fingers crossed, watchful waiting. And this was presented at the plenary session of ASCO 2 years ago then, again, immediately practice changing, where we see that there was a profound benefit for progression-free survival for patients receiving consolidation targeted therapy compared with those who did not. In this study as well, what we see along the right is a subgroup analysis for progression-free survival, taking a look at all different types of subgroups to say, did men or women or patients of different age ranges have a more an indication of greater or lesser benefit? And every single subgroup indicated a benefit with consolidation of osimertinib. And so this, we know, improves progression-free survival. The overall survival data is still pending at this time, and we're still awaiting that final analysis. But one of the key questions raised is, do all patients with these types of EGFR mutations truly need that lifetime of osimertinib? Are shorter periods of treatment going to be acceptable? There is still a small population of people who are cured with chemo and radiation alone. How can we identify those patients better to be able to spare people that lifetime of treatment? Because these drugs, although well tolerated overall, still come with the price of some physical toxicities as well as significant financial toxicity. A $15,000 to $20,000 per month drug for a lifetime is not a small matter. So in summary, looking at early stage and locally advanced non-small cell lung cancer, understanding the NGS status, the mutation status of a cancer is important across every stage of lung cancer. This completes the diagnosis. A patient who has a KRAS G12C mutation with a KEAP and an STK has an entirely different cancer than a person who has a RET rearrangement or who has a ROS1 rearrangement, or who has only an ATM mutation. These all are very different diseases, and we cannot lump or consider them together. The neoadjuvant, perioperative, adjuvant, and consolidation treatment is increasingly then disease specific. And we need to know at the very beginning of a person's diagnosis exactly what that entire diagnostic array is before they get any treatment. We have an evolving array of guided therapies that has the potential to further improve outcomes. And there's a tremendous amount of data that will be evolving and pending. And this field is going to keep changing and keep changing quickly. We also know that ctDNA and the minimal residual disease, or MRD, selected risk assessment and monitoring strategies are going to increasingly have a role, although we don't have one defined method of doing this right now. And those will have a role for prediction of those patients who may have a better or worse outcome, for those who may need further treatment or not, as well as prognosis, how well a person is going to do overall, and hopefully then guiding intervention in, again, a more refined and specific way. So now let's talk about advanced non-small cell lung cancer. And historically in the past, there still remains a tremendous amount of nihilism about people who are diagnosed with stage 4 non-small cell lung cancer. And I deal with this in clinic every single day, where people say, I don't want any treatment, I'm just going to die. And that painful cartoon description of Joe Chemo from back in the day still resonates with people. And the media presentations of people getting treated for cancer still resonate. However, it's important for us to realize some of the tremendous advances that have been made in survival for people who have disease that may still not be able to be cured, but can be more chronically managed. So here on this slide, what we're looking at are some of the key studies that help to demonstrate a benefit of the addition of immune therapy for chemotherapy, where on the left we see patients who with non-squamous non-small cell lung cancer with histology selected chemotherapy with a pemetrexed-based regimen, who had a significant benefit in survival with the addition of immune therapy. And the key part here is looking at the fact that this is 5-year survival that we're measuring in these patients, where close to 20% of patients are still alive 5 years after their diagnosis, with their cancer being chronically managed. For squamous cell lung cancer, where different chemotherapy is needed because of the relative response for different histologies, with a taxane-based regimen, here we also see that about 18% of people with squamous cell lung cancer are still alive 5 years after their diagnosis. So this is no longer we are no longer faced with a diagnosis and a prognosis simply of months. There are some patients who can be here many years later. However, these numbers, as you see, are still painfully small, and we have a long way to go. Likewise as well, for patients who have PD-L1 high disease without a driver mutation, but those who have a PD-L1 expression level of 50% or greater on their tumors, with simply immune therapy alone without any chemotherapy, then about a third of patients can be alive 5 years later, just with immunotherapy alone. And so we have multiple different checkpoint inhibitors approved in the first-line setting for a patient with newly diagnosed lung cancer who does not have a driver mutation, who has a high PD-L1 expression level. And for those patients, we could say almost 32% of patients are alive in 5 years with just that checkpoint inhibitor. So there is hope out there. There's also room for improvement. Now, why do we talk about not giving immune therapy before targeted therapy? So there were studies before that looked at this situation. And it is important to keep in mind that we can't just immediately act on a high PD-L1 level without getting that NGS back. It's easy to do so because PD-L1 is an IHC test that comes back in about 24 hours. NGS testing could take a couple of weeks to come back. And so you get one answer right there and you want to act on it, but we don't have the full diagnosis. What we also know is that many patients with an actionable driver, EGFR, ALK, ROS, RET, and others, will have a high PD-L1 level, but we need to put it in context. So in one of the earlier studies, this was a small study, but for patients who had just PD-L1 positive lung cancer with an EGFR mutation, patients were given checkpoint inhibitor as the first-line therapy, so starting with immune therapy. However, and it's also important to know that over 70% of patients had a high PD-L1 expression. These patients can have PD-L1 expression of like 90%. They're very high. However, after the first 11 patients, enrollment was stopped for this smaller study because only one patient in that entire group had disease response. It was subsequently found as well when they reanalyzed that patient's tumor that that one patient who responded actually did not have an EGFR mutation. That patient had EGFR wild type disease. Also, there were 2 deaths within 6 months of enrollment. And that's really important because patients with these types of EGFR mutations have a multi-year survival with targeted therapy. But these patients then had 2 deaths within 6 months. So they had gotten immune therapy, progressed, went on to their targeted therapy, and then died, including one who died from pneumonitis. And so the take home from this was that the timing of the targeted therapy and immune therapy raised concerns about toxicity, but that also we don't see signals of efficacy. Another example of looking at this, there was a study that looked at the order of treatment, checkpoint inhibitor first, disease progression, then going to targeted therapy with osimertinib. And in that analysis, there was a 15% incidence of severe immune-related adverse events. So these are checkpoint inhibitor-induced immune attacks that were occurring after the patient stopped the checkpoint inhibitor and went on to targeted therapy. Now, that's important because severe immune-related adverse events, typically we think of an incidence in these low single digits, not in the double digits. And these occurred within just a few weeks after switching over to osimertinib. These required steroids, they required hospitalizations, they were life-threatening things, which were not only pneumonitis, but could also include colitis and hepatitis and others. However, if patients started with a targeted therapy, received that targeted therapy, had progression, and then later went to a checkpoint inhibitor, there were no events of a severe immune-related adverse event. So that was also key. Looking at the order of treatments, checkpoint inhibitor first, followed by a switch to a targeted therapy, sets patients up for number one, they do not receive a benefit with their first-line treatment. They do not receive a benefit with the immune therapy. Number two, they are being set up for the risk of significant severe toxicity. If we treat these patients out of order with the wrong thing, we can harm our patients. We need to know their entire diagnosis before we treat. So now let's move on and talk about some of the other mutations. And I want to talk about KRAS mutations as one of the more common that we see in lung cancer. So KRAS, the cartoon may or may not come across on the screen here. I think that it's going to. KRAS mutation. So KRAS is a GTPase. And based on ligand signaling, when activated through the receptor, then will cycle between an active and an inactive state based on that extracellular stimuli. When a KRAS mutation occurs, then instead that the KRAS is consistently on and consistently functioning, and that then triggers downstream PI3K, RAF, and other signaling processes that drive tumor growth and metastases. So this occurs in about 25 to 30% of patients with lung cancer. Again, though, multiple different types of KRAS mutations that behave differently. The most common that we see in about 13% of patients is a KRAS G12C mutation. And so this is very hard to target, though KRAS previously was felt to be an undruggable, untargetable target. Part of the reason is if we look at, if this is a cartoon of some of the conformational changes between the on and off state. There's a high affinity for GTP, and there are challenges in the very small binding pockets. Now, breakthroughs were made previously with some of the now FDA-approved targeted therapies of sotorasib and adagrasib, as we see with others under investigation, with the identification of the switch II binding pocket for which drugs could be designed to go and bind to shut down function. And now there are the development of multiple other agents that are coming along, including what we think about here as tri-complex inhibitors binding to a different location. These are also what we call or are termed molecular glues, depending on which one. And this may have some familiarity based on a lot of the recent press, again, after the presentation at ASCO for patients with pancreatic cancer, of a pan-RAS inhibitor, daraxonrasib, that also is under investigation in lung cancer. And there are multiple other types of KRAS inhibitors that are under investigation and coming. So what is also known previously is that for this population, although patients with a KRAS mutation can have a benefit with addition of immune therapy, when trying to add the first generation KRAS inhibitors like adagrasib, sotorasib to immune therapy, there was a very high rate of severe toxicity, including severe liver toxicity, that made these drugs not safe to give in combination. So enter into this, on this slide, an example of one of the newer generation KRAS inhibitors, not yet FDA approved, but still under investigation. So olomorasib is one of the newer generation KRAS inhibitors. And in this study example, looking at here, when given in combination with a checkpoint inhibitor in the first line setting, then we can see that there is a significant disease response that exceeds what we would expect to see with just the checkpoint inhibitor alone. And for this, or for these early studies here, smaller number of patients than either in the first line setting, never diagnosed, or in combination looking at those patients who've had disease progression on prior standard of therapies, and given the combination, then we are seeing seeing very intriguing durations of progression-free survival, as well as patients, over 2/3 of patients over a year into treatment without progression of their disease. And there are very similar numbers between a PD-L1 any status and those who are PD-L1 high. So these were found to be more tolerable and safer to give in that combination, and are now prompting further investigations. And so here, what is seen are some of those examples of that duration of response, where patients aren't needing to come off therapy with toxicity. They are able to maintain disease control, as well as very intriguing progression-free survival. Now, these are still small numbers, and we have to see this in larger studies. So the toxicity profile now with the newer generation does not appear to be additive with this, although there are patients who require a dose reduction. It was about a quarter of patients needed a dose reduction of olomorasib. Transaminitis in this population was treatable. So this has supported then further investigation into other lines of treatment. So the SunRay-1 study, for example, is a study for patients who have metastatic lung cancer, who are then being treated for PD-L1 any expression with either standard of care chemoimmunotherapy or the addition of olomorasib, or for those patients who are PD-L1 high, which is also standard of care single agent immune therapy or immune therapy with olomorasib. Data from this is pending. Also then looking at, for those patients with resectable disease, once patients have finished their neoadjuvant and then surgery and are going on to adjuvant immune therapy, this is evaluating the addition of olomorasib in that setting, It is also being evaluated in addition to consolidation immune therapy, again, for patients with KRAS G12C mutations. All of this data is coming, and we will see how that looks and whether this may change, again, our next standard of care. So this is a very tiny snapshot of the many pending studies for KRAS G12C. There are early stage through late stage trials looking at other agents as well, divarasib, adagrasib in combination with immune therapies, bispecific antibodies of different types. We see both a on and off inhibitor, so some of the next generation of treatments, clamp inhibitors and others. We also look at antibodies with different types of novel immune therapies with vaccines and targeted therapy and immune therapy checkpoint inhibitors. So this is a really dynamic field, and we will see how this changes. So touching briefly as well on some of the next generation checkpoint inhibitors. Checkpoint inhibitors with just a PD-1, PD-L1, or a CTLA-4 antibody are not going to be our be-all and end-all. They have a profound impact and a profound benefit, but we still need to make improvements. So ivonescimab is part of the next generation of bispecific antibodies, where this is an bispecific antibody to PD-1 as well as VEGF. And this is a study, this is an example of a study that was just presented again at our international meeting a few weeks ago. This is a randomized phase 3 trial for patients with metastatic squamous cell lung cancer. This was conducted only in China, but showed a significant benefit in overall survival with this bispecific antibody compared with just the standard PD-L1 inhibitor with chemotherapy. This is intriguing, but some of the big caveats here is this was done exclusively in one country, and we have to see how this efficacy translates in a more global and more diverse population. As well, in this study, with 266 patients in each arm, there were only 10 women enrolled in the study arm. So again, we do not have an interpretation or implication of how this may roll out in the actual representative population. Intriguing, but not yet practice changing. So in the last few minutes here, I want to talk about advances in small cell lung cancer, talk about nihilism. For many decades, we had very little impact that we could make in this extremely fast-moving, extremely mortal disease. With the addition of checkpoint inhibitors, we had 2 different studies for patients with extensive stage or metastatic small cell lung cancer, where adding immune therapy upfront to chemotherapy significantly improved overall survival. With the different studies, different checkpoint inhibitors, this was either a 2 to 3 month difference between the two. It's not felt that they were profoundly different in terms of their outcomes overall. We don't think that there's a significant reason for superiority of one versus another, but at the end of the day, both provided survival benefit over chemotherapy for those eligible patients. Once patients complete the first part of chemotherapy in combination with immune therapy, the next step is maintenance single agent immune therapy, checkpoint inhibitor alone. This was a trial, the IMforte study, that looked then at switching and adding a different chemotherapy, lurbinectedin, to the checkpoint inhibitor, and showed a significant improvement in overall survival with adding that chemotherapy to the checkpoint inhibitor. We see the atezolizumab arm below on its own here, where overall survival, and I want to keep this part in mind as we look at some of the next studies, there's a 3-month improvement in overall survival. Now, once we're in that maintenance setting, OS for the combination was about 13 months. Now, this does come at the price of more chemotherapy toxicity in those arms, but again was practice changing. Here in subgroup analyses, as well, looking at gender, age, and other types of status, then all subgroup analyses favored a benefit of the combination of treatments. Looking at limited stage disease, This was a trial that was presented 2 years ago at ASCO as well at the plenary session. So setting the field here, for patients who have limited disease, the standard of care treatment is curative intent chemotherapy with radiation, followed by monitoring before this. And so similar to the Pacific study that we looked at for non-small cell lung cancer, in this trial, after completion of curative intent chemoradiation, then patients were randomized to receive immune therapy versus watchful waiting. And here there was a significant benefit in overall survival, outcomes favoring all subgroups evaluated. Now, we look at these curves and one thinks there's not a lot of difference between them. Maybe it's a few months, just like what we saw in the extensive stage setting. However, in this setting, we have to look at our time since randomization, and this translated into almost a 2-year difference in overall survival. So now we're talking years of benefit, adding the checkpoint inhibitor in the curative intent setting. Again, immediately practice changing, but not the end of the story. So here now I'd like to touch base and talk about bispecific antibodies in this space. So tarlatamab is a bispecific T-cell engager, and this is targeted toward DLL3. So tarlatamab then has 2 different arms on the antibody, one binding to CD3, which is a marker on T cells, the other binding to DLL3, which is a protein expressed in small cell lung cancer. Binding to both of these essentially connects the T cell to the small cell lung cancer, triggering T cell activation, triggering cytokine release. This causes tumor killing. The cytokine release recruits further T cells and further treatment or further cancer destruction. So this type of a T cell engager does not require MHC class 1 recognition to be active. And so this trial was evaluating those patients who had received upfront treatment for extensive stage small cell lung cancer, had cancer progress, and at that time, the next treatment is our chemotherapy options. This was a global study randomizing to the T-cell engager versus standard of care chemotherapy, with a significant difference in overall survival here with tarlatamab compared with the previous standard of care chemotherapy. And so here again, we see a multiple month improvement, almost 6-month improvement in overall survival with tarlatamab compared with chemotherapy. And here we see improvements as well in that progression-free survival time before cancer is growing again, with what may potentially be a small tail on this curve, but we will have to see. Right now, the presumption is not that these are curative, but just that they are helping to maintain disease control. Now, the thing to keep in mind about T-cell engagers, we have to look at the adverse events. These are not chemotherapy drugs, and they have different toxicities than other types of bispecific antibodies. With activation of the T cells, with release of cytokines, then the key things to keep in mind are that patients can be at risk at first, especially with high disease burden, of cytokine release syndrome. So once those T cells are releasing cytokine, you can have a cytokine storm. And this can provide significant or dangerous toxicity and needs careful protocol-based monitoring. In this study, however, those patients who developed cytokine release or neurotoxicity ICANS, the majority of the incidents were grade 1. These were mild and manageable with fewer relatively serious toxicities. And the study was able to then amend, at first patients required an inpatient 48-hour observation with starting treatment, but then they were able to amend to outpatient monitoring. What's interesting to note is that although we are watching for these toxicities, more patients had toxicities and more severe toxicities with chemotherapy than they did with the bispecific T-cell engagers. So patients did better, had better quality of life, essentially, with the tarlatamab. So cytokine release syndrome is something that we manage and follow based on the CTC-AE toxicity grading scale, and we follow something called the Lee grading scale, and has very protocol-specific advice for monitoring and management. ICANS, or immune cell effector associated neurotoxicity, is potentially a very life-threatening complication that needs to be followed and monitored as well. So these have led to this requirement for step-up dosing, where patient gets a low dose of treatment of drug, and then with the next week they get their full dose of treatment to essentially ease into that treatment. And it requires monitoring and management skills at a specialized center. That is becoming increasingly more manageable across the board globally in the oncology space, but is something to keep in mind. This has prompted questions about looking at the maintenance setting. Then, can we put these into the maintenance setting where that single agent checkpoint inhibitor was before? And so this was an early phase study, a phase 1b study, that looked at either maintenance checkpoint inhibitor with atezolizumab or durvalumab. Could this be given safely? And so in this study, there was a 20% incidence of cytokine release, but there was only one grade 3. However, a chunk of patients still required tocilizumab to intervene with the earlier grades of CRS. The average onset for ICANS was about 9 days after a dose. So this needs to be monitored beyond the being in hospital. One of the tricks of this agent and the DLL3 T cell engagers is dysgeusia, an altered taste for food where patients can describe food as tasting like cardboard wrapped in a paper napkin. And patients can have a significant amount of weight loss. Calorie intake and nutrition becomes a very important thing to talk about and focus on. However, what we see on these curves, again, this was not looked at for survival, but essentially giving the tarlatamab with either one of the checkpoint inhibitors didn't show any signal that any were significantly different. So it could just be with a checkpoint inhibitor. Here in the maintenance setting, median overall survival still immature, but over 2 years. We were looking at 13 months before. So small numbers of patients, but very promising, and we will see where this field moves. In the last few moments, just touching base on antibody drug conjugates in small cell lung cancer. There have been antibody drug conjugates developed toward DLL3 as well as other proteins that are expressed in small cell. Some of the first generation, like rovapatuzumab, tesirine, were stopped because of toxicity and not much activity. Ifinatamab deruxtecan, or IDXD, is an antibody drug conjugate targeting B7H3. And in earlier studies so far is showing activity in very heavily pretreated populations with significant durations of disease control, and now being evaluated in earlier lines as well as in combination with T-cell engagers, where in these heavily pretreated populations here, we're seeing an overall survival when we would expect to see it maybe a few months, overall survival of 9 to 12 months. So this is intriguing. Adverse effects of the ADCs are primarily chemotherapy type effects, the myelosuppression, nausea, vomiting. Sacituzumab is a TROP2 antibody drug conjugate, also showing activity, small number of patients, but again, this intriguing duration of disease response. More to come. So in conclusion, in an hour, we could only very briefly scratch the surface of the treatments and the nuances of immune therapy in lung cancer. But the more we understand these as individual diseases, the better we can treat them. And this is not going to become more simple. But given that, there has really never been a better time to research and combat lung cancers. And with that, I'd like to thank our teams here at the Cancer Institute. And I'd like to thank you very much for joining this morning, and I'm happy to take questions.
Thank you, Dr. Sanborn. That was really fascinating. Um, so different from things early in my career. So, um, just a couple of questions. I think there's a bill before the legislature regarding requiring insurance companies to pay for biomarker testing. I don't know if that has to do with the testing that you do for cancers.
It absolutely does. And it's actually a really important issue because there are many times that insurance will still try to block and select for the biomarker testing and does not want to approve the biomarker testing, which includes this next generation sequencing. What we know in studies is that if we test both tissue and blood for a patient, we have a better identification of the entire array of these genomic markers that have an overlay that with implication for treatments. But we still run into in different places and with insured or underinsured patients in which insurance companies will deny the claims or will only allow one and not the other, and patients are partially treated. We know that, unfortunately, although this is really important information, in the United States, the minority of patients actually get their full genetic testing of their tumors and are treated with only partial information at best. And that is part of why our outcomes are poor. We have studies that have been published in large populations that show that when we have those markers up front, access to the appropriate targeted treatment is improved and survival is better. And so patients have a right to know their diagnosis, their full diagnosis. And so that is something that we have been trying to push to say that we need to be able to be allowed to test for and give a person the full information of what their cancer is. Just as it's not acceptable for a breast cancer to be diagnosed with breast cancer, but not have ER, PR, HER2. You can't just have a diagnosis of lung cancer.
Thank you. Another question, you mentioned some patients that they have this idea of chemotherapy toxicity and they resist treatment or even sometimes referral for treatment when facing lung cancer. I've run into that. Uh, any ideas on how to talk to those patients or resources to give them to read about?
Yeah, that's a very great question and a significant challenge because of the nihilism that's out there. And one of the things when I'm talking with a patient who may or may not be wanting to consider anything further is we start with, let's just talk about it. Let's talk about what your diagnosis is. Let's talk about what the stage is. Let's talk about what the options are and what their side effects are. And my job as an oncologist is to provide information so that the patient can then make decisions about what they want to do. So an example was in my clinic just yesterday with a person who was newly diagnosed with a very aggressive form of lung cancer. And we talked about what the standard of care treatment is, side effects, benefits, a clinical trial option with the addition of a novel drug, what that might mean. Also, we talk about the alternative of not pursuing treatment. And I explain to patients at every decision point that we make, I always also talk about the fact that it's okay to say thanks, but no thanks. And we talk about what that would mean. And we talk about prognosis as they want to discuss it. And then let them have that information to make decisions. So many times when a person goes, they have this perception, if I'm going to see an oncologist, they're going to force me to get treatment or they're going to push me to get treatment. And really what it is a consultation to just talk about it and say, what does this really mean? And so anytime you can say, it doesn't hurt to just talk, that can open the door.
Thank you. Another question, are there age limits for treatment with some of these newer therapies?
That is an excellent question. When we think about lung cancer in the United States in particular, the average age of diagnosis of lung cancer is 72. So this can occur in an older population, although that's not what I consider old. But in my clinic, there are still a significant proportion of patients who are in their 80s or even 90s who are candidates for all kinds of different treatments, whether it's radiation, systemic therapy, chemotherapy, immune therapy, other. What we know from our clinical trials is that age itself is not a cut point for relative benefit with treatments. Instead, the critical impact and the critical factor is what we call performance status. How well a person is, how much they're able to be up and active in their day, as well as looking at other comorbidities like heart function, kidney function, etc. So if a person has a poor performance status, they are in bed resting, not able to be active. So they're resting more than half their day, active less than half their day. Regardless of age, many of these treatments will give more harm and will shorten life. And so there are times we'll have even a young person for whom we cannot safely treat. But if a person is up and active and moving through their day, they can have a benefit in both time and quality of life with these treatments, regardless of their age. So it's the array of the rest of a patient's comorbidities and that performance status that are really the predicting factors.
Great. Thank you. I'm not seeing any further questions. So again, thank you for a really excellent and fascinating presentation. I personally learned a lot. So thanks.
Well, thank you for the invitation to join. Thanks, everybody. Please take care.